Hi guys, this is Dr. Tapesh Bansal again with another lecture, this time on antibiotics in sepsis part 2. And I presume that you know a little bit about antibiotics, and we will try to cover those points and those concepts which are not clear to many people. And this is going to be regarding the ICU antibiotics, the antibiotics we use in sepsis, and I will also talk about the resistance mechanism. Resistance is very important because at the end of the day, it's the resistance which kills the patient generally. So, how do you get resistance? And how does a patient get resistance even while he's sensitive to the antibiotic? When he's getting those antibiotics and he dies. So, we shall see all this and let's go now. So, for the intensivist, I feel that antibiotics is the most important topic. Why? Because sepsis is a leading cause of death in the ICU. You all know that. Therefore, if you don't have your antibiotics right, if you don't give the antibiotics, he's not going to survive. So we have to know the antibiotics, the intensivists, the physicians, or whosoever is treating the patient in the ICU for sepsis. Maybe a pulmonologist, maybe a nephrologist, maybe a gastroenterologist, everybody gives antibiotics. So even it's these guys who got to know this topic about antibiotics. Now, we know we are running short of antibiotics. The world is running short of antibiotics, but why? Is there a problem with our brains, our researchers, our clinical research, our clinical scientists, or is there something else? Well, guys, the answer here lies uh, in the finances. The amount it costs for the development of a new antibiotic, the R&D. And before you can recover all this, the bugs become resistant. So nobody is willing to invest. That is the crux of the problem, why we don't have enough antibiotics. Nothing wrong with our brains, nothing wrong with our research. And we don't need robots to invent a new antibiotic. It's the finance. Now, I assume you know a little bit of PKPD, the MICs and the area above curve, so I will not touch that. A word about hydrophilic drugs. Drugs which are primarily in the fluid, the extracellular and the intravascular space, and do not go to the tissues to any great extent because they are hydrophilic and not lipophilic. And this is very hydrophobic, that is lipophilic, and they bind to the tissues. Now, you all know, guys, that if a drug goes to the tissues, then its volume of distribution increases because most of the body is tissue, while only 20% is actually extracellular water of the body weight. So the distribution of hydrophilic drugs is much less as compared to lipophilic. So what is the clinical relevance here now? You ask me, what is the clinical relevance? Why should we know hydrophilic and lipophilic drugs? Because for a hydrophilic drug, as I just said, the volume of distribution is less. It's mainly the blood and the extravascular fluid. So supposing there is a drug, let's say meropenem with 2 mics per liter concentration, serum concentration, and you give around 4 liters of fluid. So approximately the serum level of meropenem will decrease to about half, right? That will not be the case with lipophilic drugs. Because when you add 4 liters, that distributes across with the drug throughout the body practically. Therefore, you got to maintain the serum levels for hydrophilic drugs by giving extra dosing, higher dosing as compared to lipophilic drugs, because their serum levels fall when you give fluids in sepsis as compared to lipophilic drugs. And these are the hydrophilic drugs we have given in the list. Most of the drugs we use are hydrophilic. There are lipophilic drugs also like tigecycline, etc. But the armamentarium comes from there. Now, what is post-antibiotic effect, inoculum effect, and heteroresistance? So these are some definitions we should know, especially useful to our students, and don't really have too much of a clinical significance. So the post-antibiotic effect refers to the persistent suppression of bacterial growth that occurs after the drug has been removed in vitro or cleared by drug metabolism and excretion in vivo. So this is typical for aminoglycosides and to some extent for levofloxacin. Then what is inoculum effect? This effect is defined as a significant increase in the MIC at high inoculum compared with the standard inoculum. The clinical significance of this phenomena is uncertain. And what is heteroresistance? We've all heard about heteroresistance for vancomycin for staph. So this is a normal MIC on testing, but a subpopulation has a higher MIC. And when you do the MIC, because the population which is having a higher MIC is very, very small, therefore it does not alter the MIC when you do the susceptibility testing. But when these bacteria start growing in the human body, in the human tissues, during the infection, the resistant population, which is very small, starts burgeoning and thereby leading to failure of the antibiotic. This is also seen for Acetylobacter and colistin, apart from vancomycin and staph. Here you see there's loss of pore into carbepnams. Here you see there's beta-lactamase production. Here there is efflux. All this can be operating in the bacteria, giving rise to multiple mechanisms of resistance. And similarly for certain other antibiotics and bacteria. That is one of the reasons why you have pan resistance in a bacteria. And one must also appreciate that when you give an antibiotic, let's say you give ceftriaxone. Now, for ceftriaxone, you need ESBL production to cause a resistance. So the bacteria becomes resistant by becoming ESBL producer. At the same time, there's a link up between the various genes in terms of resistance to different antibiotics. And resistance to ceftriaxone by production of ESBL further confers resistance to other antibiotics also, like aminoglycosides, to quinolones, because of inherent mechanisms. The links are present within the bacteria to make it MDR from a single drug resistance. So we will not go into further depth because that is beyond the purview of intensivists, clinicians, physicians. But I think I was able to give you a picture of the scenario, the big picture, without going into the smaller shots. Now, what exactly is happening here is quite a ghastly scene. That's right, it's quite a ghastly scene. And what you see right in the center is the beta lactamase. The beta lactamase molecule, and there are 600 of them. There are 600 of them, maybe more, and causing death for a couple of decades now, and will continue to do so because this is going to be there. Then these will not be active. That's how you go about it. So I hope you understand this. Now we come to the property of beta lactamase inhibitors. So as we know, these are the classic clavulanic acid, sulbactam, tazobactam, and these are the newer ones, avibactam, vaborbactam, and there's some more. Now they have a different structure as compared to the initial ones. And what about the efficacy of these three? Well, if you see here, tazobactam and clavulanic acid are almost the same, and sulbactam is inferior in its activity. So what about the properties of a BL-BLI combination? That is, if you have amoxicillin with clavulanic, and you have ampicillin with sulbactam, and you have piperacillin with tazobactam, one would be superior. Well guys, the properties of BL-BLI are determined by beta-lactam and not the inhibitor mostly. That should be borne in mind, is the main molecule which determines the activity. We shall see this as we go on. So, which is better? I just told you that sulbactam is inferior to tazo, but that is a secondary condition. The more important thing is piperacillin is more potent than ampicillin. Now both are penicillins, but piperacillin is the most potent of the penicillins in terms of its activity against gram-negative, and it also covers Pseudomonas. Ampicillin is inferior in its activity against gram-negative. So pip-tazo becomes superior to ampicillin sulbactam. Then ceparazone sulbactam is inferior to piperacillin tazobactam, because sulbactam is inferior to tazobactam, though ceparazone may have the same activity as piperacillin. So that is how you decide which BL-BLI combination is superior. At the same time, we must realize that ampicillin sulbactam is excellent for Acinetobacter. Why? It's not because of ampicillin, it is sulbactam. And sulbactam, just sulbactam IV is not available easily everywhere. So you have to give generally in combination with ampicillin, but sulbactam is the one which destroys Acinetobacter, and it's a wonderful drug. It works when nothing else works. So please bear that in mind. Now we come to phospho and Tg. I presume you know a little about phospho and Tg, so I will not tell you about those things, but I will tell you what you may not know and what is relevant. Before that, we know that phospho and Tg are not recommended to be used alone. Why? One, resistance emerges rapidly on therapy. Serum levels are below MIC, especially for tigecycline, because it has a narrow therapeutic index. If you give too much to cover the MIC, then it will cause toxicity because the therapeutic index is low. And in vivo studies have shown that the results are not good when you use it as monotherapy. You may be very good with your PK/PD, that it is not good because of this, because of that, but at the end of the day, what the drug is doing in the body may be a little different because of various factors. For example, because there is pus, the drug does not reach the bacteria. It does not penetrate through the pus. And there are so many other factors. Just to give you a small example, that is typical for amikacin. And for tigecycline, it does not go through the urine, so it's not good for the urine. And so on and so forth. So studies have shown at the end of the day, that is what we need, that results are not good with monotherapy. Now a few words about phosphomycin. Very important Phosphomycin, if you give it for a couple of days, your sodium starts going up. Why? Why does sodium go up on phosphomycin? Because 1 gram contains 300 milligrams of sodium chloride. So that's very important. Salt, hypernatremia. Then it causes hypokalemia because there is tubular loss. Phosphomycin impairs tubular absorption of potassium because we all know that potassium is filtered through, then absorbed, then secreted, then reabsorbed. So it interferes with the absorption of potassium and there's a leakage of potassium. Similarly, there can be a leakage of phosphate and calcium also sometimes. Then importantly, always give 8 gram loading, and more than 16 grams is needed for GNB other than E. coli, for which it is very good. Then because of electrolyte disturbances, they can be brady at times with high doses. Please bear that in mind. And how you do your phosphomycin levels is also very important. It can go to the bones, it can go to the CSF, it can go to the lungs. Not good for abdomen as compared to TIGI, but excellent for urine, that you all know. Not good for pseudo and acetone, do not cover that. And we have oral sachets, 3 grams every 72 hours for minor UTIs only. So that is a few pearls about phosphomycin, assuming that you know a little bit about phosphomycin. Now the second drug is TIGI. Where do we give TIGI? Very good for abdomen and soft tissue. Do we give it for pneumonia? Some of you may have heard that it is not recommended for pneumonia. Yes, we give it for pneumonia. The dose is 200 loading and 100 BD, higher dose, double the dose. Why? Because the parenchyma needs a higher dose of tigecycline. All about penetration. Like I told you in my first the previous slide, why certain drugs fail in vivo despite having good PK/PD. There's a difference. This is a difference here. Then it's mainly for gram negative, has some anaerobic activity, covers staph also to some extent. But it does cause hepatitis and pancreatitis in certain patients. It caused in my patients. In 2 of my patients it has caused. So this also occurs, hepatitis and pancreatitis. And if the patient is sick, this can push the patient over the edge. So that is to be borne in mind. Have a look at the amylase and the LFTs if the patient is kind of deteriorating, which is not explainable on TIGI. And there is a black box warning in septic shock. And what is the black box? That when TIGI was used for sepsis, the overall mortality was actually a little higher than when other drugs were used. Now this can be interpreted whichever way you want. At the end of the day, we are using TIGI, but do not use this preferentially. Only if you don't have anything, then you use TIGI. Now, this wonderful drug called polymyxin, which is highly confusing to many, and I shall try to enlighten the twin towers for you as best as I can. Now, polymyxins were widely used 30 years ago. Just mycin was widely used 30 years ago. That time it was for gram positive. So both these drugs
are like old wine in a new bottle. PK and PD of polymyxins even today is not clear. We do not know what is the final metabolism of the 2 polymyxins. The MIC for colistin is well established, but the MIC for polymyxin is extrapolated from the colistin MIC. So that is a problem with polymyxin B. That is polymyxin B. Because you have to extrapolate it. The MICs, that is the breakpoints, have not been determined by CLSI, the regulatory body in the United States, and the UCAST, which is the regulatory body for microbiology or infections in Europe. Now resistance is emerging rapidly for the 2 polymyxins, first reported from China because they should feed the pigs, etc. the livestock with colistin. Poly B is overall better. Why? One, it needs no dose modification in renal failure. That's very important because once you don't have dose modification, you know your serum levels are going to be good because the serum levels are of paramount importance for killing the bacteria. For colistin, even today, the drug dosing in renal failure is not clear. So there's a problem there. Secondly, poly B is less nephrotoxic. Overall, the nephrotoxicity of the two colistins, the two polymyxins is overstated. It is not that nephrotoxic, and nephrotoxicity is reversible to a great extent. Then there is heteroresistance in Acinetobacter for the polymyxins, therefore should always combine with another drug. For the other bacteria, if your MICs are good, you can use polymyxins as monotherapy. Then a very important thing is neurotoxicity caused by the polymyxins, which is increased with other nephrotoxic drugs or drugs which impair the nerves and the neuromuscular junction, especially aminoglycosides. In the setting of renal failure, toxicity is increased. Toxicity is increased in calcium depletion, in magnesium depletion, because they affect the neuromuscular junction. And you may get even cranial neuropathies, partly because of neuromuscular effects, not because of the nerve getting involved as such, which can occur at times. Direct nerve involvement is also known to occur in certain cases, and it can lead to delayed weaning because there is weakness, because your neuromuscular junctions are weak, your nerves are weak sometimes, so there can be delayed weaning, especially in renal failure, I told you, and with other drugs which may impair renal function or neuromuscular function like aminoglycosides. And delayed weaning may be difficult to pick up because if the patient is in altered sensorium, it's difficult to assess the motor power. It is difficult to assess the motor power. How are you going to know there is muscular weakness if the patient is not going to respond by lifting his limbs? Or you got to do a EPS then. EMG nerve conduction studies. And very importantly is apnea. Why is apnea important? Because you extubated the patient. Patient is breathing spontaneously, he's getting better, and he's on polymyxins. And he suffers a respiratory arrest. Why has he suffered a respiratory arrest? Because of polymyxins. They have impaired the neuromuscular junction and suddenly he stops breathing. So be cognizant of this very important side effect. And how do you reverse this? Can you reverse this apnea? Yes, you give intravenous calcium. That may get him out of complete apnea, and then you can institute your invasive ventilation. So this is very important. Then use in obesity. Dear friends, there is no dosing recommendation for obesity. Neither is dosing very clear in obesity for other drugs also. But as per the European Society of Intensive Care, the dosing in obese patients should be taken as per the adjusted body weight, and the adjusted body weight is 1.25 times the ideal body weight. So you multiply the ideal body weight into 1.25 and then you use your dosing calculations. Now if your GFR is good, that is above 80, then you can use 12 million loading for colistin. Now your patient is in urosepsis on colistin and the crrt increases. What should you do with colistin? There's no other drug. If there's another drug, then you switch the drug. Understandable. Don't persist with colistin if you have another drug, if the creatinine starts rising on colistin. Now, if the only drug available to you is colistin, then you continue with colistin on a lower dose as per the GFR. The rationale being, one, that you don't have another drug, you have to save his life. Second, even if the renal failure
persists, even if the creatinine increases to some extent, it is generally reversible. And when the creatinine is going up on colistin, you really do not know whether colistin is causing the increased creat or the disease is causing the increased creat. That is the rationale. And colistin or polymyxin B causes nephrotoxicity by causing acute tubular necrosis. Rarely it may cause acute interstitial nephritis. So you can investigate the urine for the two conditions, the cast, the eosinophils, etc. etc. Now we have carbepnams. I presume you know a little bit. So just a few things about carbepnams. Can you have imipenem sensitivity and meropenem resistance? Can you? You can. I'm sure some of you know this, but many of you may not know this. This is because of different mechanisms of resistance in the bacteria to imipenem and meropenem, specifically the efflux pumps. I showed you in the beginning the efflux pumps. The efflux pump may be such that it is pumping out your meropenem and letting your imipenem go in. So then it becomes sensitive to imipenem and resistant to meropenem, and so on and so forth. There can be different resistance mechanisms leading to different sensitivity and specificity for meropenem and imipenem. Now, the patient has encephalopathy. Will you give him MO or Mero? Which one will you give? I hope you got the concept that encephalopathy predisposes to seizures. So here the answer is meropenem, because the incidence of seizures with meropenem is much less than imipenem, and especially in renal failure. Imipenem throws seizures. So this is to be borne in mind. Now, is there anything better? Yes, doripenem. Doripenem is a drug of choice because the seizure potential with doripenem is almost nil. The next question is, there is a resistance to carbapenem, but culture sensitivity is showing sensitivity to aztreonam. Now we all understand carbapenems have a much broader spectrum of action and much more potent, and aztreonam is a lower drug, so as to say. So does this happen? Yes. How? How does this happen? Well, we have to understand the different enzymes, the different resistance mechanisms. So here the answer is that if the bug is producing carbopylamides, which are actually NDMs, then aztreonam remains sensitive, because NDM type of carbopylamides do not inhibit aztreonam. But at the same time, aztreonam is destroyed by other beta lactamases also, which the organism is producing. If that is not the case, then aztreonam will work if it is showing sensitivity, and there may be resistance to meropenem and imipenem in these organisms because they are producing NDM where aztreonam is working for you. This is a picture from a colonoscopy shot. Any idea what this is? I hope the picture is good. Well, I thought this is a good picture. This is actually Pseudo-Membranous Colitis. And why I am showing this to you is that the carbepnams have quite a low incidence of Pseudo-Membranous Colitis as compared to a lot of other antibiotics. And we know one of the predisposing factors for Pseudo-Membranous Colitis is multiple drugs that the patient is on. So you have to stop the drugs, but sometimes you have to give one drug, and there this comes in handy. You may give carbapenem. The other thing is seizures. And what is the connection between carbapenem and seizures? One, we know that they cause seizures. Reason why I'm showing this to you is that it has a strong drug interaction with valproate. Carbapenems lower the serum levels of valproate markedly, so you should be cognizant of that. And valproate dosing may have to be increased, or you may have to do serum levels if the patient is getting valproate along with carbapenem. Now, is Mero better than ME for gram-negative sepsis? What is the answer for this? Is there any difference? You all know that Mero is used much more. It is supposed to be better, but why? Well, the answer is for gram-negative, Mero's coverage for pseudo is a little better than imipenem. That's about it. There's nothing else. And there are differences in gram-positive. in Enterococcus faecalis, in Faecium, but for gram-negative sepsis, the only difference is in pseudo, and that's where we use carbepnams. Now, why don't we use ertapenem? In many areas of this world, ertapenem is not used so much, but it's a wonderful drug. The beauty being that's a single shot per day. It's a single shot per day, but it's not active against pseudo and acinetobacter. That should be borne in mind, and the cost comes down significantly once you give ertapenem because a single dose and it's not so expensive. So please use ertapenem wherever possible. It works well. And here I've tried to show you the relative use and the spectrum of the different carbopylamines. So imipenem is the broadest meaning. It has the maximum usage the world over, followed by imipenem and then doripenem and ertapenem. Doripenem has a restricted use. Generally, it's not a favored drug, but here the height shows the spectrum of the two drugs, which is equivalent. IMI is less than meropenem in terms of Pseudomonas, and ertapenem is much less in terms of Acinetobacter and Pseudomonas. But IMI does have advantages for Enterococcus, but then again, Enterococcus is not that important in most of the parts of the world. Overall, meropenem has the best coverage. This patient has arrived at the night, a 50-year-old lady, diabetes, coronary artery disease, dual antiplatelet therapy, and she is in hypotension, tachypneic, tachycardic, with SATs of around 90% on room air. This is the X-ray that she brings with her, done in another hospital outside, and you are on call at night, you are looking after the ICU. So you have to now decide as to what to do. We have to hit hard and hit fast because the patient is obviously sick and you think the patient has septic shock because the X-ray looks like a lobar consolidation in the right lower lobe. So the first thing is now that we should ensure the diagnosis of sepsis. These are the mimickers of sepsis, that is 15%, which include many things. Example, myocardial infarction with shock, acute pancreatitis, pulmonary embolism, anaphylactic reaction, supposing she has been given a drug outside which has caused anaphylaxis, then even viral autonomic failure, supposing this is a viral infection in the lungs or anywhere else. So we have to look out for sepsis mimickers, and in a study it has been shown that 15% of the patients who were supposed to be having sepsis initially at the outset did not have sepsis after some degree of investigation. Second, tropical infections. There is a distinction between tropical infections and sepsis. The distinction is sepsis, as we understand, is caused by pneumonia, by UTI, and soft tissue infections, abdomen, meninges, lines, devices, or unknown. Around 20% of the patients have unknown source of sepsis. So my question to you is, what is this unknown source of sepsis? Interesting. Why should there be an unknown source of sepsis? And this is in blood culture positive patients. So think about it and let me know. So going back a little, We have tropical infections in the form of dengue, in the form of malaria, in the form of scrub typhus, leptospirosis, and relapsing fever. And there are some other infections which you are aware of, which we see from time to time. Now, the tropical infection has a distinct history of fever. It has at least 5-6 days of fever with some vague symptoms before it manifests as shock. That is to be clearly understood. It does not cause shock so soon. That is sepsis. Eventually, it is going to cause sepsis. And the distinction is important because the investigations are different, and more importantly, the antibiotics are different. What do you need for rickettsial? Doxycycline. You're not going to give doxycycline for bacterial pneumonia. So that distinction is very important. Whether it is a tropical infection or it is sepsis, classical sepsis. And the distinction comes from your good history taking and your knowledge of the tropical infections which come to the ICU. And they will vary from one geographical region to another geographical region. Then we have viral sepsis. You know, when I was a medical student, there was no viral sepsis. But we continue to progress. Research is done in the labs, and we realize more and more, and we all know what COVID is doing today. That is all virus. All virus, havoc across the world, havoc across the human body, havoc across all organs of the human body. What are we talking about? Sepsis, every organ in the body. Myocarditis, thrombosis, brain is gone, and you know what all it is doing. I shall not expound upon that further. We do not know the degree of viral sepsis. There are no numbers on that because it is very difficult to suspect it, and more importantly, you can't send PCR in the blood for all the viruses. It is not possible, neither are the tests developed. But we do know that 20%, up to 20% of respiratory samples for pneumonia admitted to the ICU have been positive for different viruses. So up to 20% of pneumonias coming to the ICUs have a viral PCR positive. Though that does not necessarily mean that viral pneumonia is the cause of pneumonia, but definitely it is up to 15 to 20%. The reason I say it is not definite is because there is colonization. The viruses colonize the respiratory tract, and it becomes difficult sometimes whether it's a colonizer or a pathogen. And at the same time, do remember, influenza in the respiratory sample is always a pathogen. It is never a commensal. And then, like I told you, we have to distinguish septic shock from other types of shock. Please keep your brain open, and we have to think along different paths. For example, I will tell you the importance of thinking here. Your brain will try to take the easiest way out. I'm speaking this from personal experience. So what is the easiest way out? There is hypotension, there is tachycardia, hypoxia, is going to be septic shock, right? That's easy for the brain. Now, if you try to think laterally along another path, you have to exert. So you don't try to exert. The brain doesn't want to exert. But you have to make the brain exert to try and make the correct diagnosis, because like I told you, 15% time is not septic shock, and this is true for any other condition. You have to think laterally. It's just like you want to drive your car, you would drive your car across the simplest path, wherever the traffic is least. And you would not like to go through smaller routes or by lanes because they'll be congested and it'll be more difficult to drive. So please think laterally, force your brain to open up and exert to get the correct diagnosis, because the diagnosis is very, very important. Risk factors. You know the risk factors: any drug intake in the last 3 months, any hospitalization, because this predisposes to resistant bacteria. Severity is very important. More severe, harder you have to hit. You have to get the doses right and doses high. Then we do not normally need gram positive in India because this is more so in the West. If you are working in the West, definitely gram positive is more than gram negative, but in India and in certain parts of Southeast Asia, you do not have so much gram positive, it's mainly gram negative. And when you're trying to cover gram negative, do give a dual cover because you do not know what antibiotic is going to work against the bacteria. You do not know what exactly the bacteria is. So you have to give two antibiotics till you get your cultures. Or you are able to identify clearly what is the cause of the patient's condition. And gram positive, definitely if you are in the West, in Europe, North America, or if there are specific indications. There is a list of 10 conditions which predisposes one to gram positive. Foremost among them is soft tissue infection, then a patient on maintenance hemodialysis, patient of burns, and supposing the patient has a line, then again he's predisposed, if he's coming from outside, or if he's got an immune deficiency which predisposes him to staph, so on and so forth. So you should be aware of the conditions which predisposes one to gram positive, that is mainly staph. The dose you have to get right, we will discuss the dosing further, and you should be aware of the resistance patterns. What antibiotics you start depends entirely on the resistance pattern of the bug coming from the community, which will be different from what you get in the hospital. This is of paramount importance, and to empirically start meropenem or colistin or piperacillin tazobactam because it is written in the literature is entirely wrong. What is applicable in India may not be applicable in Japan, and may not be applicable in Europe, and may not be applicable in North America, and in South America will be different. Each geographical area has its own resistance pattern. But in a nutshell, the resistance pattern in Southeast Asia is much more than in North America and in Europe, where the usage or rather the consumption of antibiotics is tightly controlled. We have much more resistance here in India. And similarly in the developing world. The entire developing world, the under-resourced world, is having much more resistance. Side effects are very important. You should not give a drug which is going to cause some side effect which is not tolerable. And renal function, hepatic function should be taken into consideration. Don't give nephrotoxic and hepatotoxic drug respectively. And drug interactions. It is difficult to remember the drug interactions. There are so many. But a few drug interactions you should know. For example, in a patient of pneumonia, we often have to give cover for atypical pathogens with either a macrolide or a quinolone. Now, both these drugs cause QTC prolongation. And often we get elderly patients who have cardiomyopathy or for some reason have a prolonged QTC, a baseline prolonged QTC. And we predispose them to Tosad if we give a drug which further increases the QTC. And amongst levoflox and Azi is the prototype. It increases it much more than levo. So you would go with levo if your QTC was borderline high or high. Similarly, if you give fluconazole, it has a lot of drug interactions, and fluconazole also increases QTC. So that is about QTC. And at the same time, you have positive drug interactions. For example, if you give aminoglycoside to the beta-lactam, it is supposed to have a synergistic effect. Now, so you should be aware of some drug interactions. If you give aminophylline with levoflox, you predispose the guy to seizures because both of them excite the brain. Simple drug interactions and those commonly happening should be known to you. And please remember, time is life, and the drug selection is life. In a study done by Kumar et al. In 2010, published in Chest, it was shown mortality increases by 50% if your initial therapy, which you choose, does not cover the organism, and if you do not start the antibiotics as soon as the patient comes to you with hypertension, mortality goes up exponentially with every hour. So get the antibiotic coverage right, give the highest dose in septic shock, and start as soon as the patient comes to you after a quick initial assessment. He may not have sepsis, right? I told you there are some mimickers, so you can always de-escalate after 8 or 12 hours. You cannot afford not to give if there is some suspicion. Please remember, his life depends on your antibiotics. If you do not get them right, he's not going to go home. Now, we have this patient, it's been around 48 hours, 24 to 48 hours, and he is not improving. So you start thinking as to what is to be done. You looking after the patient and you want him to get well and you're trying your best, but he's not improving. So what are the causes? What is possible? Foremost is that your drug is not correct. Either it's wrong or it's called a suboptimal dose or the organism is resistant, even if your drug is correct, or there is a focus of infection. Supposing he has pneumonia, you missed an empyema. Huh? Or he could have been having some accompanying pericarditis. Pneumonia can cause pericarditis. Or he does not have sepsis. It's possible he may not have sepsis. So you have to reevaluate. Supposing he's been bleeding because of GI bleed because of antiplatelet therapy. He's not had hematemesis, that's alright, but 15% of the patients with upper GI bleed do not have hematemesis. He may have had a shock due to your MI, cardiogenic shock, and he'll be silent because the patient is diabetic. And like I said, he could be having anaphylactic shock also. Other possibilities, a complication has developed. That is, initially he did not have a pneumonia, an empyema. You got a good chest X-ray, you looked at it carefully, you're good with the X-rays, you got a CT also done, there was no empyema, but it developed after 24, 36, 48 hours. Or you got some abscesses going to the liver and spleen. Or your supportive therapy is not good, you're not given the proper fluids, either underdosed him or overdosed him and it has gone to the lungs. Huh? You're not ventilated him properly if he's ventilated. And last but not the least is that he is developing in vivo resistance. And we will talk about this in some detail as we go on. So what do you do now? You think your diagnosis is correct, he's got pneumonia, he's got septic shock, so you change the antibiotics. We will not discuss the details of which antibiotic because we're trying to discuss the principles. There can be so many antibiotics you can give. Now, the culture report comes and you got the right antibiotic, it is sensitive, and you are happy, you work with him, you de-escalate therapy, you wean him off and he's going home. Great. Everybody is happy. Now, sometimes it does happen that the patient does not recover despite your antibiotic being correct. So why does this happen? Why does this? Foremost among this is that he has developed resistance on therapy, which is very interesting. Why should a patient who's getting full dosing of your antibiotic, your meropenem or a colistin or a ceftazidime, avibactam, develop resistance when he was initially susceptible as per your cultures and the culture sensitivity was good? Can this happen? Yes, it does happen. We shall see. Or the patient was immunocompromised. These are the two foremost reasons, and immunocompromise is very important because it tells you why the elderly succumb, why the patients with multi-organ diseases like CLD, CKD, advanced diabetes, cardiomyopathies, poor heart ejection fraction, they succumb because they have their immunity compromised. They have their immunity compromised. And why is the immunity important? Immunity is important, you know, because it acts in conjunction with the antibiotics to kill the bacteria. So even if your antibiotic is good, you are killing off a lot of bacteria, but the immunity has to be there to finish the job off. So that is why if the immunity is not good, the bacteria continue to proliferate and you end up losing the patient. And then you can always acquire another infection after 2, 3, 4 days, which does happen. You get a VAP, you get a UTI, you get a line infection, everything happens, you know that. Or he's got some unrelated complication, maybe MI, an embolism, anything, an arrhythmia, something, you all know that. But the first two are of foremost importance. That is to be understood, and we shall see the mechanism of resistance, especially on therapy. Now, a few minor subtle points are there. One is in vivo and in vitro difference can be there sometimes in sensitivity. That is, your culture shows sensitivity, but it is not actually sensitive. That does happen sometimes because of the microbiological techniques. Then you may not get adequate serum levels because of renal failure. It's very difficult to get the exact dosing in renal failure. Nobody knows the exact dosing. Then drug interactions can alter the drug levels, and poor drug quality. If you're using a drug of an inferior quality, it can alter the response and the efficacy of the drug. For example, we had a patient of malaria, severe malaria, ARDS, and proven by your smear and by your antigen test. And what happened was that after 48 hours, despite artesunate, he was not improving. So we were all wondering, because artesunate resistance is of a very, very minor nature in this part of the country. And then we just had a look at the kind of artesunate he was getting, and we found out that it was spurious in nature, and we replaced the artesunate with the right brand, and the patient responded. So this is another very important thing, especially for India and the developing world, because there are so many brands and not all the brands are up to the mark in terms of the quantity of drug and the quality of drug in the vial or in the formulation. And last, again, but not the least, is pharmacogenomics, upcoming area of research and understanding. That is how your pharmacology is dictated by your genes. Individuals have different genes which determine how the body is going to respond to pharmacology, that is different drugs. And once in a while, a patient will have such genes that he will not respond appropriately to that particular antibiotic. Either there may be inherent resistance somewhere, or the metabolism may be hyper. He may be metabolizing too much of the drug. And so such things may happen, other things may happen in terms of pharmacogenomics. So we'll stop there with pharmacogenomics, and that is in a nutshell how you choose your antibiotic, the principles guiding the antibiotic usage, and you should not deviate from this, because this is the crux of treating septic shock. Principles. Within this realm, you choose whatever antibiotic you want to choose, but remember the principles of choosing the antibiotic, and if the patient is not responding, what are the causes, and then again reassess and again choose the antibiotic, whether it should continue, change the dose, etc. These are of paramount importance. The dose is also very important. Give the highest dosing. Do not be a miser as far as your dosing is concerned. Give the higher one if ever in doubt. Get a toxic level. You get a toxic level. So this is, in a nutshell, your MIC, your breakpoint, your MIC going a little above breakpoint, where it becomes intermediate sensitivity, and if it goes beyond that, it becomes resistant and toxicity. So as your MIC starts going up, you get intermediate sensitivity, and then you get resistance, and then you get toxicity. I will show you some antibiograms to make you understand this, and this is then clear to you what is breakpoint and resistance. What is MIC creep now? You see, over the years, the bacteria have become resistant. So, what was the breakpoint initially here has now gone up to here. So, this is called a MIC creep. Is now the breakpoint has become higher. So, what MIC you are getting, in other words, breakpoint has become higher. MIC and breakpoints are often used interchangeability, but you should not get confused. Classically, breakpoint is what is given by the international bodies of UCAST and CLSI. But loosely, breakpoint also becomes MIC, just terminology. So I was able to clarify that. And hetero resistance I've already told you. So that is about the concepts of MIC, and we shall see a few antibiotics. Now, here you see this for E. coli urine culture. This means less than or equal to 2 and sensitive. Here again, and here you have 8, which is sensitive. So this is not as good as amox here or amox here, because you don't have this sign of less than 8. If you had this sign of less than or equal to 8, then this efficacy would be same as that. It is not just a number 8. For example, here you have less than 1 and here you have less than 2. So which is better? Which is better? In terms of sensitivity, both are same. But, probably you would choose your amoxicillin or your amoxicillin chlorogenic acid, depending on what the clinical scenario is. But in terms of sensitivity, and which is what we are discussing here, 8 means it is less sensitive, not because of the number, but because this less than or equal to sign is not there. And this sign is again here, but this does not mean that this is less effective than this. Here you have to decide amongst which antibiotic is best for E. coli. And what is the site, what is the clinical scenario, then you decide. So we move down here, and here you see imipenem is 2, and it is not the best sensitivity, because again you don't have this sign of less than or equal to 2. And amikacin is less than or equal to 2 at the value of 2. So that is what I was trying to understand. Each number is different for each antibiotic and each bacteria. And here we come to resistance. Say the other way around, greater than. That means the MIC is more than 16, which is more than the breakpoint. The breakpoint is lower than 16. That is how it works. Your MIC has crossed the breakpoint, whatever it is, and at 16 it is highly resistant. Similarly, for less than 2, it means your MIC is much less than the breakpoint, which is somewhere here. So you are able to achieve a good MIC, which will take care of the killing of the bacteria. So guys, about mutation occurring on therapy, if you try to understand the problem of mutation and resistance, we got to first understand a little bit about resistance. Resistance has been there from eons. In 3000 BC, tubercular bacilli have been found in Egyptian mummies. So you can estimate the number of millennia of years since we've had bacteria. And these bacteria have always had genes, and these genes determine their resistance. Certain bacteria are inherently resistant to certain antibiotics from those many millennia. Now, resistance also occurs when there is mutation spontaneously. It has been occurring over the past many centuries, and when the mutation occurs, it gets passed on to the next generation and the next generation, and so on and so forth. Mutation genes also pass from one bacteria to another bacteria of another genus or species at the same time, also laterally, by different processes like transduction and conjugate transmission, etc., etc., which we really don't need to know. Then mutation occurs if they are, exposed to bacteria, though you are exposed to antibiotics, even though you are not trying to kill the bacteria. Supposing you're giving ceftriaxone to a person because he's on a endotracheal tube. A lot of people do that. That is actually wrong. Just having some bacteria in your bowel sample or in your tracheal sample does not mean that the bacteria has to be eradicated. So you're giving ceftriaxone, and that bacteria or that particular population of bacteria develops resistance because they have to survive. And this resistance to ceftriaxone, which is actually ESBL, gets passed on to other bacteria, and often the resistant genes are interlinked in the bacteria. Resistance to ESBL leads to resistance to quinolones, to aminoglycosides, and even to carbopnamases. That is one of the mechanisms of MDR, and that is why we should not use antibiotics indiscriminately, and we should stop them as soon as we realize there is no infection. So an intriguing question is, like we had seen in that case, the patient gets appropriate therapy as per sensitivity, appropriate antibiotics, and he can die. So despite being bombarded with the right antibiotic, the antibiotics manage to survive. And they survive because they mutate on therapy. One of the reasons for failure of therapy is mutation on therapy, like I showed you earlier. Now, what is the mechanism for this? As I just told you and I've showed you here, these genes for resistance are present from before, and there are certain other genes which are normally there. They have a lot of genes which determine resistance and sensitivity. So here we have a gene which is actually sensitive to the antibiotic in the bacteria. So we have this population of bacteria, and we have to now try and understand what really happens. What happens is that despite bombarding the bacteria, some of the bacteria will survive, because when you are giving the antibiotics, the bacteria comes under stress and mutates. Now, why does the mutation occur? Mutation occurs because there is an inherent tendency for the bacteria to survive. There is an inbuilt program. Just to give you a very simple example or an analogy, if there were 100 people in a room and a fire broke out, or they were subjected to a terror attack, which is a fashion these days, sadly, they would try to survive, and if not all, a couple of them would survive. And they survive because they think of a mechanism to survive. A mechanism comes from the brain. The brain thinks of a way to escape, and one or two of them will manage to escape, rest will sadly succumb. Similarly, these bacteria manage to survive, one or two of them out of the entire population, because even they have to survive like us. They cannot think, that is the only difference. But the signaling pathways, the intracellular pathways in these bacteria are probably the same as those which we have, which lead us to survive. The only difference being that we have evolved into a much higher level of functioning and developed cognitive thinking. But at the root, the essence is the same. The intracellular signaling pathways which protect the bacteria, which make the bacteria mutate, have evolved over millions of years and developed into cognitive thinking in the human being, and that is the reason why we survive, and that is the reason why bacteria survive. Just to put it very simply, to go into intracellular signaling pathways is beyond the purview of this lecture. We were all bacteria millions of years ago in one line. Thank you. Now, fundamental question is, are resistant bacteria more virulent? Try to understand, there is resistance and there is virulence. There is a difference. Resistant bacteria are those which resist the antibiotics, but virulent bacteria may or may not be resistant. They are just hyperproliferative and give rise to severe disease. So the answer here is no. Resistance is different from virulence. It's important to understand this, because as per evidence today, the genes for resistance are different from genes for virulence. And this helps to understand what is happening to the patient. It might look like a blank statement out of nowhere here, but these are the concepts and we have to apply them. So unless we know the concepts, we cannot apply, and we will not be able to understand what is happening to the patient. That is why the concepts have to be understood and then applied at the bedside. Now, second question, are immunocompromised patients infected with more resistant organisms? What do you think? Yes, probably. The answer is no. Being immunocompromised does not lead to more organisms, but it leads to failure of therapy and poorer outcome. Because if you are immunocompromised, then after the infection, it is difficult for the patient or the host to fight the infection, because he needs immunity to fight the infection along with antibiotics. And this also translates into what is bacteriostatic and what is bactericidal, the eternal debate in antibiotics, which has not been resolved even today. I'm sure you will think that we should not give bacteriostatic, most of you, but others would say there's no difference between bacteriostatic or bactericidal, like my team members say. But the fundamental concept again, the concept, what is bacteriostatic and what is bactericidal? Any bacteriostatic drug is actually bactericidal, but the MIC goes very high for a bacteriostatic drug to be bactericidal. And that MIC is actually toxic. That is a fundamental difference between bacteriostatic and bactericidal. So we cannot give such high doses, because the MIC becomes very high, the serum levels become very high and they are toxic. So we give a lower dose which inhibits the bacterial growth but does not kill the bacteria. That is bacteriostatic. A bactericidal drug is given at the dose at which its serum levels or its MIC is not toxic but good enough to kill the bacteria. So if the bacteriostatic drug does not kill the bacteria, then how is it effective? It is effective because it acts in conjunction with the immune system to a great extent, unlike the bactericidal drug, which does not require that much support from the immune system. So a corollary here is that if the immune system is weak, your bacteriostatic drugs will not work. One, so do not give in immunocompromised patients. And second, if there is a florid bacteremia and the patient is really sick, then again don't give. That's, I think, common sense. So these two situations, don't give bacteriostatic drugs. We know linezolid is wonderful for pneumonia. It is better than vancomycin and it's bacteriostatic. But we do not give linezolid if there is concomitant pneumonia and sepsis, or if the cultures are positive. This is from what I've just explained to you. Do we give linezolid for endocarditis, staph endocarditis? We don't give. That is why we don't give. Similarly, there are other drugs like tigecycline is bacteriostatic, and there are some others. Teicoplanin is bacteriostatic. So these things should be borne in mind. And an important thing again is that there has been a meta-analysis of a large number of trials for bacteriostatic versus bactericidal, and the outcome has been the same. So the debate continues, nobody is sure, but I've given you the concepts. And at the end of the day, most of the people would not be comfortable giving a bacteriostatic drug for a seriously ill patient or a patient who's immunocompromised. Then the final answer is with you. The final choice is yours. Now, a very interesting drug is intravenous Septron in sepsis. Can we use it? So, if you have a good MIC, good sensitivity, then you can use IV Septron. But as a last resort, if you don't have anything else, then you can use IV Septron. It's very good for Stenotrophomonas, it's very good for MRSA in soft tissue infection, and it's very good for UTI. Not so good for gram-negative sepsis or urosepsis. But like I told you, if there's no option and the sensitivity is good, go ahead. But at the same time, you must remember it has a multitude of side effects, a plethora of side effects, and a lot of drug interactions. And this is the dose, and below 10 ml you cannot use it. If the GFR is less than 10, then you cannot use it, and you have to modify the dose below 30 ml. So that is another option that you have amongst your antibiotics. And earlier there was a lot of resistance, but as the usage of Septron has died away, sensitivity has re-emerged. Nature. Antibiotics and bacteria are a lot of nature. Now friends, we are moving towards the final sections. This is renal failure, dosing and impact of survival, and we shall see how important dosing in renal failure is and how difficult it is. It is very well known that sepsis, if accompanied by AKI, has a higher mortality than without AKI. And also, if there is non-septic AKI and septic AKI, then again the mortality is higher for septic AKI versus non-septic AKI, as you can see here. This is sepsis and this is ICU mortality, this is total hospital mortality, that is the entire stay, and here you have septic AKI, the mortality has gone up from 7.5 to 19.8. So you may say that there is sepsis without AKI, now he's got AKI, so the mortality will go up. Fair enough. But here we have non-septic AKI. This is ICU mortality 13% and this is 20% with septic AKI with the same creatinine levels. And one of the reasons here is the patient with septic AKI are generally on dialysis. And dialysis is known to cause a lot of problems with serum levels because your dosing is not good enough in patients on dialysis and also in renal failure, but much more in dialysis. You do not get adequate serum levels. So your mortality directly increases by 25 to 50% when you're on RRT. And because of this, dose should be individualized for patients who are on RRT. Just don't give the standard dose every 8 hours or 12 hours or once a day for the remaining duration of treatment. As long as the patient is on dialysis, you have to change the drug dose and modify it as per the condition, as per the creatinine, as per the urine output, as per the volume of distribution, as per the clinical condition, as per the hepatic condition, and so many other factors which determine your efficacy of dosing. And serum levels should be ideally monitored. TDM is the future for antibiotic dosing, and it is coming up. That I will talk about in my next lecture, part 3. This is part 2, part 1 I have already taken, and there is no overlap. So in part 3 I will cover whatever else is remaining. Now I have used this book, The Kidney by Brenners. This is the Bible of nephrology, and whatever it states is the gospel. Okay, and because papers are very controversial and conflicting, it becomes very dicey. But when you have the Bible of a subject, you can always quote it if it's a recent edition, and this is just 1 year old. So I've taken a couple of shots from this book and I've directly pasted it, and I will read it out to you. So here we go. There is a paucity of dosing algorithms to guide pharmacotherapy derived from investigations of the PK and PD of multiple dose studies in patients with AKI. Most of the critical care literature and almost all FDA or EMA product labeling containing drug dosage recommendation derived from observations with CKD and end-stage kidney disease. So that is how you have got your dosing, which is not accurate enough. It is established from CKD, and we have AKI in the ICU when we dose the patients. So again, another statement here you see, no controlled clinical trials have established the efficacy of these dosage recommendations. So again, we have some flimsy grounds. So you can understand the problem with dosing, and if you don't dose properly, you will not get your serum levels. If you don't get your serum levels, your patient will die. And that is why there is much more mortality with renal failure. Not so much with AKI, but much more with dialysis, because what drug you are removing, how much drug you are removing is very variable. As you see here, it says the effect on drug removal of HD, peritoneal dialysis and CRT is variable, and the values in the table are more qualitative. So the kind of dialysis you are doing, the kind of membranes you are using, the amount of dose of dialysis that you are giving, all determine the washout of the drug from the serum through the dialysis, and can be very variable. So dosing is a very big problem. On dialysis, we still do not know. And here is what I just told you. High rates of removal can lead to therapeutic failures. So the way forward is therapeutic drug monitoring. There is no other way. It's very difficult. But as a clinician, you should understand the PK and PD of drugs. there are a few factors which determine the peak and PD, which you have all read. That is the basics of antibiotics in the ICU, how the serum levels are affected by albumin, by pH, by the volume of distribution, by uremic toxins, by hepatic clearance, by drug interactions. So if you know a little bit of this and you understand this, then you can dose individually. In the sense, dose can be individualized for the patient. Every dose is not 2 gram TDS or 1 gram TDS or 1 gram PD. You can vary the dose up and down if you understand a little bit of the fluctuations in the drug levels. And let us hope something comes from space for drug levels. Now, the question about dosing. So, if you see here right at the bottom, GFR, if it's normal, dose is 500 to 2 gram Q8 hourly for meropenem. And you see for 10 to 50 GFR and less than 10, it is very specific, Q8H and Q12H. That is the dosing, and the dose is of course there. But the dosing interval we are trying to focus on. And for CRT and HD, again, it is very clear, the dose and the dosing interval. Now, when we give the dose of meropenem in renal failure or on dialysis, we all know it has to be reduced, and we all know that it has to be reduced by 50% or whatever as per the GFR. And we do not focus on the dose. But the dose is also very specific, as you see here. Now, what is the importance of the dose? The importance of the dose is, here if you see, this is less frequent dosing here. And you can see the time the drug is spending above the mean level. And that is the major factor which determines meropenem efficacy. And here you see frequent dosing, and you can see in blue and the time spent above the mean levels. So this is very important. Dose the patient properly, not only as per the amount of drug you are giving, but also the dosing interval. Be very clear about this. Don't just give 50% of the dose divided twice a day or once a day or 8 hourly as per your convenience arbitrarily. This is very important because for beta-lactams and carbopylamines, time above MIC is the most important factor which determines efficacy. And here again, the maintenance dose. This is something I would like to stress upon. It is clearly said maintenance dosing regimens for many drugs should be initiated at normal or near normal dosage regimens and adjustments made later on after the initial 24 to 48 hours. So do not decrease the dose of meropenem and your carbopylamines and your beta-lactams for the first 24 to 48 hours. Give full dose. Give full dose is very important because the battle for sepsis is essentially the first 48 hours. If you get it right, your patient will go home. So what am I saying? I'm saying don't decrease the dose of meropenem for the first 48 hours. Give the full dose. 2 gram 8 hourly. There is no specific guideline as such, but there is enough evidence, enough of literature to suggest this, and this is right there in front of you from the Bible of nephrology. And I have used this and it has made a difference to my patients. And the logic is there right in front of you. Now, a very fundamental question is, how do you calculate the GFR to give the dosing for your drug in the ICU? Because creatinine lags behind, and suddenly you have to change the dose or adjust the dose or fix the dose. So the best way is to take a timed 8-hour urine sample. Take a timed 8-hour urine sample and calculate the volume, calculate the creatinine in there, multiply the two and see the serum creatinine, and serum creatinine into your GFR is equal to the 8-hour urine volume into the creatinine in that urine sample. So you get your GFR during that 8-hour period. And that's how you dose your drugging if you are having renal failure, new onset or changing creatinine. That is the best and the suggested way as of now. Crrt formula can also be used in case you have a problem in collecting the sample or you do not want to collect it. But this is the best way. But this is a very interesting thing to know, and this should be practiced. Now, biofire is a new technique to identify bacteria, and this is in lieu of blood culture. The basic advantage and the most important thing is that it picks up very early, in a few hours only. Few hours means it can report in 3-4 hours itself. And sensitivity and specificity is very high, can be used in blood, CSF, your respiratory sample and your stool sample, so it practically covers everything and gives you the resistance very fast, so it saves a lot of time, gives you the right drug and results in better outcome. It's a little more costly, but at the end of the day it is much more cost effective. So please use biofire wherever possible. I have used it and it has been wonderful. I sent a CSF sample once. I was not sure what it was. There were a few cells, and I sent the CSF culture also, and within 6 hours I got a report it is H. influenza in the CSF, which is very rare. The patient actually got the meningitis in the ICU. It was not a community acquired meningitis, and I was very surprised, but I started ceftriaxone and the patient got up after 72 hours. The CSF culture came after 72 hours and it was negative, as it is normally. So just to give you an example. And this is what the antimicrobial resistant genes report looks like, depending on what genotype resistance is there. That is shown in the right. And these are some examples of genotype resistance which I showed you earlier. Depending on what genotype resistance you have, you'll have to choose your antibiotic. Of course, you always need phenotype resistance when you have genotype. You cannot do without phenotype. You may or may not have genotype resistance, but you have to have phenotype. And these are some of the new antibiotics available across the world, but in India we have only ceftazidime, avibactam. And in my last lecture I talked about it, so I would not cover it, but I will talk about cefiderocol and plasmomycin. The drugs on the right are not yet available in India, but they are good drugs, but more suited for the West because of the combination. They cover the resistance better for the West than for our country. And cefiderocol is a drug recently developed in Japan. It has a Trojan horse mechanism because it actually binds to iron molecules and passes across the membranes through the iron pathways, iron channels, and therefore is not subject to the resistance mechanisms of beta-lactams, as you can see on your right, wherein there is either an efflux mechanism to pump the drug out, or there is a problem with the porin channel alteration which does not allow the drug to go through. So these two mechanisms are bypassed. That's why it's called Trojan horse mechanism. So, and it's active against most of the resistant bacteria as of now, but it's not available in India. It's available in a very few countries. And this is the molecule binding to the iron, as you must have understood. And plasmomycin is a aminoglycoside, a new aminoglycoside, which acts against gram-negative bacilli, resistant to other aminoglycosides, acts against CRE, and recommended for urosepsis monotherapy and as dual therapy with others, yet not available in. And last few slides, the appropriate use of antibiotics. It's very important. It's a social responsibility. And as you can see in the center, increased overall mortality of ICU with inappropriate use of antibiotics because of all these factors. It promotes MDR bacteria in the host and causes aspiration pneumonia, resistant bacteria. It causes resistant bacteria in the gut microbiome, which can lead to a secondary hit with resistant bacteria, as gut is the source of secondary hit many a time. And from the gut, when the patient goes down, it can spread in the community, the resistant bacteria. Alteration in the gut microbiome can lead to C. diff. Then there can be adverse reactions if you use unnecessarily. And when the patient's re-hospitalized in the 90 days after that, then he'll have MDR bacteria, because that is a risk factor which you should always ask. When the patient is admitted, always ask for 2 questions, at least whether there was a hospitalization in the last 90 days and whether he received antibiotics in the last 90 days. And of course, the other risk factors are also there, but these 2 are of paramount importance. And last but not the least, the cost, which is a very big concern. Unnecessary antibiotics escalate the cost, and if you get complications because of antibiotics, you are further compounding the problem. So appropriate use of antibiotics, that is what is called stewardship. Antimicrobial stewardship, a very fashionable term which everybody has heard of, but nobody practices. Please practice it. What I have shown you here is not just for the sake of knowing. I know you all know this, but please practice it. It is a social responsibility. So you stop the antibiotics if there is no infection, irrespective of 2 days, 3 days. Once I was told it's only 3 days, how can you stop the antibiotic? You'll get resistance. So that is quite incorrect. And de-escalate. Once you get the culture sensitivity, de-escalate. If the sensitivity is very good, otherwise don't de-escalate. If there is a poor sensitivity, intermediate sensitivity, etc., then you don't de-escalate. And then avoid feel better if on one antibiotic at least. A lot of times certain clinicians will say, oh, he's on the tube, so let's give him some minor antibiotic. He's on Foley's, let's give a minor antibiotic. They just feel better. But the patient doesn't feel better at the end of the day. So don't just give antibiotics unnecessarily. And do not try to eradicate all cultures. Bacteria will always be there once the patient has tubes and lines from the respiratory samples, from the urine samples. It's a very common error again to give antibiotics for any urine culture positivity, any sputum sample positivity. The patient throws a fever, then you, without evaluating the cause of fever, you just send the cultures, or if the culture is already there, it shows some bacteria, you would think he's got a UTI or a respiratory tract infection, you have to start antibiotics. That is not actually correct at all. You have to evaluate for the cause of fever and rule out all the cause of nosocomial fever, and then if you don't have, you ascribe the fever to your urine infection or to your respiratory infection, wherever the sample has come from and is showing culture positivity, and then you give the antibiotics. This is a very, very common error which leads to gross overuse of antibiotics. And if you use your antibiotics indiscriminately, like I just showed you, at the end of the day, your patient is going to suffer. One. Secondly, other patients are going to suffer in the ICU. And third, the community will suffer, and so on and so forth. It just spreads. Use serum levels if you have, and don't treat Candida cultures also. Respiratory samples of Candida are not to be treated unless there is a very heavy growth, and that is because it causes tracheal bronchitis and not pneumonia. Tracheal bronchitis, that also in the sense of actually causing airway narrowing and element of obstruction. There is no pneumonia descending from the respiratory tract into the lung parenchyma ever. It does not occur because the immune mechanism in the lungs is such. Candida pneumonia, my dear friends, is very rare. If it occurs at all, it occurs from candidemia. And of all the autopsies done in one study, only 50 Candida pneumonias were seen. Out of all collective autopsies, I do not remember the numbers, but it's a vast number going into thousands. It's very rare. 50 Candida pneumonia only in a vast series, collection of series. It is almost not there. And if it does occur, it is in the setting of candidemia. And again for urine, if you get Candida in the urine, you are going to give something, fluconazole or whatever you want to give. You will not give an echinocandin. Will you give an echinocandin if you got Candida in the urine? You will not give. Or will you give? You don't give. Why? Drug of choice for Candida UTI is fluconazole. Find out why you don't give echinocandin if you don't know, and find out when Candida in the urine is treated. There are only 3 conditions. Candida will always be there in the urine. It's very common. You change the Foley, fair enough if you're getting Candida, but you don't give fluconazole at the drop of a hat. Please. Cultures are to be treated with respect and understanding. Otherwise, you harm everybody. I harm everybody. We harm everybody. Not only that patient, we harm the ICU and we harm the community. It's a social responsibility, not only a professional responsibility. Please try to understand. We are the intensivists. We have to be very careful about this. And dosing in obesity, I think I told you about this. You have to take 1.25 times the actual body weight, which is known as the adjusted body weight. So it's a little more than the ideal body weight, but less than the actual weight. And then you use the adjusted body weight for dosing, for your calculations. This is the best recommendation as of now. Even that is not correct, but that is what is said in literature by the European Society. So guys, at the end of the day, take home message, less is more. Yes. And here, just trying to emphasize to you our social responsibility and the global spread of antibiotics. You know, most of the ICUs are here, first floor. So we give the antibiotics here, and you can see it goes everywhere. It flies across also. The resistance flies across, and closer to home, it goes out and back to you. Out and back to you, and it is a problem created by us. He may survive by an overdose. He may not survive also. If he is going to survive, he may not survive. For example, indiscriminate use of pancreatitis has led to an increased mortality. It is well established. There is a very strong tendency to start antibiotics in pancreatitis without evidence of infection. And these patients have a higher mortality. So that is one thing. You are harming the patient, like I said. And even if you think by giving a cocktail of antibiotics or bombarding him, you are sending him home. His family members or someone from the community is going to come back with a bug which is not going to respond to what you had given, and he will eventually expire. And you can see it's going everywhere. It's going, just look at it. It's a beautiful picture, a fantastic picture of how antibiotics spreads in the community, guys. So please write your antibiotics carefully. You know, it is said that a good lawyer knows the law, but a successful lawyer knows the judge. So just to twist it around a little bit, a good clinician knows the antibiotics, but a successful clinician knows how to use the antibiotics. So with those words, my dear friend, I would like to conclude part 2 of antibiotics in the ICU. Now we are dealing only with the ICU antibiotics. Antibiotics can go on and on and on. You can take 15 lectures on antibiotics, and with that I'm coming to the end. These are the recommended books. Mendel's is a new edition. It's a beautiful book, 200 pages you have to go through for ICU antibiotics. After that, you will be a master of the knowledge of antibiotics, and then you use wisely, and you should be able to use, and you will use. So that is the way for you. If you really want to use it, and like I said, antibiotics is the first thing that we have to know to save lives. Yes, sabd means FAME in English. Okay? Plus. Thank you guys.